I'm going to run through our third case of this session. Here are my conflicts of interest. And I'd like you to meet Natalie. Natalie is a 26-year-old who lives in Glasgow, and she works from an office running a charity. She lives with a friend in an apartment in town. And like Miguel's patients there, we're in COVID lockdown, which means we can't really leave our houses unless there's an essential reason to do so. So she's working from home. She's not allowed to visit a restaurant or a cafe. She's only allowed to do limited exercise. She can go out to buy food. She can go out to see a doctor. She can't go to the dentist. She can't have her hair done. She can't see her friends. She can't visit people in their own homes. She's had asthma since childhood. She uses a preventer inhaler, HSS-Ep, and a short-acting beta agonist. And she's a good asthma patient. She comes to visit us when we need her to come. So that's once a year. And if there are flare-ups, she'll get in touch. She has had courses of oral steroids in the past, but recently her asthma has been better controlled. When she was about 18, she went to the emergency room and she told me she doesn't want to do that again. She said it felt like she was in a bath full of water with somebody sitting on her chest and pushing her head down. She doesn't want to experience that. She hasn't seen a doctor or a nurse for a year because that's about since the COVID pandemic influenced her healthcare delivery. More recently, she's been having an increased cough, some wheeze, waking at night, breathlessness relieved by her short-acting beta agonist. And like Miguel's patient, she followed her personal asthma action plan and increased her medication. So no tricks here. What's the diagnosis? Natalie has uncontrolled asthma. We're using the same checklist that Miguel's already shown you about the reasons for poor asthma control. And what we're basically trying to do is find out which of these in the purple line apply. Now, in Miguel's case, it was incorrect diagnosis. And for the sake of time, we're going to presume that as far as Natalie is concerned, we have the correct diagnosis. We have rhinitis, which is appropriately treated. She doesn't smoke, she's on appropriate therapy and so on, which leaves us with what are often the two biggest issues in understanding the reasons for poor asthma control, which is poor compliance and poor inhaler technique. So given that we're confident about the diagnosis, and Miguel reminded us that it's always important to check that, we've dealt with all the comorbidities and associated features. Is it poor compliance or is it poor inhaler technique? So like Miguel, I'm not able to see her in person. So this handsome doctor, younger than me, better hair than me, is going to speak to Natalie on the phone, and this is how the consultation went. How are you? Great, thanks. How are you? That's the problem Miguel had about his need to use an asthma-focused questionnaire. Of course, the standard reply to how are you is fine. No, the asthma. How's the asthma? Oh, not so good. What do you think happened? I think it's because I'm locked up, I don't exercise, I'm a bit depressed, I can't go out, I can't see my friends, it's all to do with COVID. Have you been taking your medication? Of course, I always do. Now, this is a feature of people who have asthma speaking to the doctors. The first thing is they want to please the doctor, and they know the doctor wants you to take your medication. So you say you take your medication even if you don't. The second one is they know what question's coming next, and they don't want to put themselves in a position of looking to be stupid, So why do you think your asthma is not controlled? Because I haven't taken my medication. Well, just take your medication then. Let's check. So what can we do? We can check a prescription record. And this is Natalie's prescription record over the last year. So you'll see she's frequently requesting short-acting beta agonists, and she's infrequently requesting her preventer medication, HSS-Ep.
How bad is this? How bad is this, John?
The problem, Sujit, is that this medication, the HSS-Ep medication she's taking, has got 60 doses in it, and she should be taking it twice a day. So each canister should last her a month. So we should be looking to see 12 prescriptions of HSS-Ep in the last year, and we're seeing nothing like that. So it is clear simply from this that she's not ordering enough medication. Maybe because she can't get out, because she doesn't want to visit the pharmacist. The systems we have for reordering medication are different just now because patients can't easily come to the practice. So there may be good reasons or there may be bad reasons, but we can see simply from this that she's just not taking enough medication. That's a very simple way of identifying whether somebody's using their medication or not. Are they ordering their medication? But there are many, many stories of patients who have ordered medication and not used it. And sometimes my nurses tell me they visit older people at home, and when they open the cupboard doors, all these asthma inhalers fall out. And the reason is they keep ordering the medication, but they don't use it. So there's some very interesting new work going on around connected e-inhalers, which are hopefully going to help us to work through this problem. And there are two currently licensed in some parts of Europe, North America, the Western world. One comes from Novartis and one comes from Teva. And these are electronic devices inside inhalers, which are now licensed. And the devices actually look very similar to, almost identical to devices we already have, which measure the timing and the performance of a person using it. I'm going to show you some data from this one, which is a prototype, which isn't licensed, but is being used for clinical studies. It's called the INCA inhaler. The INCA stands for Inhaler Compliance Assessment. It's one of these acronyms where you have to take some of the letters from the phrase and put them together. So this is Inhaler Compliance Assessment. And this team from Dublin, Richard Costello's team in Dublin in Ireland, have done some very good work. And these are the kind of results that they get. So on the left, you'll see somebody who is a very, very frequent short-acting beta agonist user. And on the right, you'll see somebody who's a very poor user of inhaled corticosteroids. And if we get it right, then we get this kind of pattern. And this is a patient who is regularly taking their medication twice a day. And the yellow dots is poor inhaler technique. Now, these devices all use different mechanisms to assess inhaler technique. The INCA device, the one I showed you there, the one from which this data comes from, uses a microphone to assess inhaler technique. The Teva device, which is the one I'm most familiar with, measures the pressure drop when the device is used to assess whether the dose has been taken correctly. So these devices are becoming much more available to us. They're not going to be particularly cheap, but if we're looking to try and identify true inhaler technique and true compliance, they're going to be very useful.
Oh, just a question here, John. I find it challenging for patients to use such complicated inhalers. Patients with asthma want life simple. So how often do you see inhaler technique as an issue in clinical practice? I mean, how?
So the first thing is that the latest e-inhalers actually look like the inhalers patients currently have. So we overcome that problem. And I think one of the things that we clinicians are going to have to do is ensure that the enthusiasts for these devices don't overwhelm a patient. But if we forget about e-inhalers for a while, you're quite right. The problem is that we don't check inhaler technique often enough. And we maybe as a second, I know this doesn't apply to you, Sujit, but some of your colleagues maybe in the UK, secondary and tertiary care physicians, hope that somebody else will do that, like the general practitioner or the pharmacist or the nurse. But the only way you can be sure it's done is by doing it properly. And when I run my secondary care respiratory clinic, I annoy the staff sometimes by spending so much time trying to explain to patients how inhalers work and making sure that they can use it properly. You'll see that in January, she started to order up more inhalers. She recognized something had been going wrong. So for some weeks now, she's identified by herself her compliance issue, and she's addressed that by requesting more and more inhalers. So if she's using more inhalers and she's not getting better, could that be because her inhaler technique is poor? And this comes back to your question, Suchi. Using an inhaler is not like riding a bicycle. It's an old English phrase, if you learn to ride a bicycle, you'll never forget. I don't know if that applies in Spain and India, elsewhere in the world, but it's said that once you can ride a bike, you never forget. An inhaler technique is not like riding a bike. It's more like my golf swing. And I have to practice and practice and practice and practice, and I have to check. And when my patients come back, I have to check their inhaler technique is still good, because inhaler technique decays over time. So you have to remind them and teach them again and keep improving it and keep it going. It's not like riding a bike.
Each and every day we are teaching our peers, health professionals, nurses, residents, specialists, even secondary care people. And what we see is that they don't know how to use the inhalers. And that's a big problem. So you cannot teach something that you haven't learned.
Excellent. No, I think that's so true. And I think the message goes out that never assume your patient is taking the inhaler correctly. And so what we have started doing is check. Everyone doesn't have the luxury of an educator or a nurse practitioner, in their practice, but at least get someone outside your clinic to maybe check how it's being taken before you consult the patient, so that you have one thing sorted out before you move on, and don't assume your patient is taking it correctly, even if he's been your patient for the last 10 years. I think that's the message that's clearly coming across. John, please continue.
My final slide is the learning points. And these, you might come across any one of these three words to talk about the issue of not taking medication. So please be assured that unless you've got very good knowledge, very in-depth knowledge of English, the words are pretty much all interchangeable. We should always be looking for adherence and poor inhaler technique, because very few people are fully adherent. Most people don't have excellent inhaler technique, so we need to address those at each and every consultation with our patients. But the patients won't admit to these issues because they want to please the doctor. And one of the reasons I went into medicine was because I recognized there was an art to it as well as a science. So it's not just the knowledge, your knowledge of the lung deposition of a particular device and the therapeutic effect of that drug. It's the skill of persuading a patient that they need to take this medication. This is how you do it. This is why you do it. This is how you're going to be successful. This is how I can help you lead the kind of life you want to lead. So I think we need to come to an understanding with our patients about the requirement for regular medication and understanding of asthma and its treatment. And we have to look at these two very common issues at every consultation to make sure that we get the best care for our patients.